It's a great pleasure to share with you our experience about young onset dementia. My disclosure, I have no special disclosure for today, but I participate in pharmaceutical trials in dementia. And we will speak about epidemiology, about the clinical characteristics of dementia occurring, especially Alzheimer's disease, occurring in young onset, and also the medical social characteristics and the difference between sporadic and family cases. And if I have time, I will say a word about the two measures of the French Alzheimer plan. It's a third Alzheimer plan we have in France, and two measures were dedicated to young patients. And I will finish by advocacy for research in young patients. So there are 6 studies that were published before 2000, but we were not sure about the diagnosis. And 3 studies were published after 2000, and unfortunately there are a lot of methodological variations about the data collection, about the size of the population, about the diagnoses that were included in the survey. And also the main issue is that we never know if people talk about people who are 65 or less at the time of the entry in the study, or if they talk about dementia which started before the age of 65. So this is the 3 studies, and as you see, the prevalence is about 50 or 80 per 100,000 people. And the extrapolation of the number of patients under 50 years of age in UK is about 18,000, including about 6,000 people with Alzheimer's disease, so aged less than 55. And we looked at the prevalence in France also, based on an estimation from the region of Nord-Pas-de-Calais. And we have about the same number, about 17,000 people aged less than 65 years, and probably 5,000 have an Alzheimer's disease. This is an estimation, but very coherent. And we looked also at patients who are less than 60 years of age, because in France we have 2 medical systems depending on the age. Before 60, it's a system for disabled adults, and after 60 it's for senior citizens, and it's not the same ministry, it's not the same rules, it's not the same aids, it's something different. It's crazy, but it's like this. And so we looked at this number of patients with dementia younger than 60, and we have about 5,000 people with dementia younger than 60, of which 1,050 may have Alzheimer's disease. This could be underestimated. So this is when we come from. When we looked at the number of patients who attend memory clinic in the north of France, about 20% had their first symptoms before the age of 60, of which a third had dementia, and about 40% had Alzheimer's disease. And the active line, so the total number of patients is increasing, probably because the dementia is more recognized now, and the Alzheimer's disease diagnosis is better made. We have another way to look at the people who ask for aids, for public aids. And there is a chronic disease protocol with a number. 15 is a number for which we can have aids for dementia. And the number of people who asked for, this is for the France, about 4,000 people who were less than 60 years ask for aids for dementia. And it doubles in 5 years, between 60 and 65, as you see. So it accounts for about 3% of all the protocols for AIDS asked in France. To see the incidence, again, there are 6 studies published between 93 and 2010, and again, the same variation in methodology, and the incidence doubles every 5 years from 60 years as well. And the extrapolation in UK was 500 new cases of Alzheimer's disease, and about the same number for frontotemporal dementia. And in France, we calculated that the number could be about 900 new people with Alzheimer's disease, age 65 years or less. And this is, again, the age at first symptoms. People, as we will see, come to the memory clinic very late, a few years after the first symptoms. Nobody thinks that it could be a dementia or an Alzheimer's disease. And this new protocol is about 1,500 new demands asking for this public health after before the age of 65. So now let's see the characteristics of these young patients. First, the main problem is the delay in establishing a proper diagnosis. In the first studies we have made, and this was in 2003, and the mean MMS score at first visit for all age, the mean was 24, and the patients who were younger than 65 had a mean MMSE at 20. And you know that the MMS declined by about 2 points at the mild stage. So you see how long it takes before people come to a memory clinic when he has an age which is not expected to have dementia. The second characteristic is that there is a lot of different causes of dementia before the age of 65, not only Alzheimer's disease, but a lot of different diagnoses, and this is well illustrated in the distribution of diagnoses we have in our region. And as you see, after the age of 60, 2/3 of the dementia are due to Alzheimer's disease alone, or with vascular lesions, or with sometimes Lewy bodies. But before the age of 60, you see that there is only a third of the patients who have Alzheimer's disease, and the second most important cause is frontotemporal dementia. And in gray, you see all the other causes, and some are very rare causes. To focus on Alzheimer's disease, what is different in these young patients is that the memory impairment is not pregnant. It's not pregnant. It's not prevalent. It's not the most important symptoms. It's usually people have instrumental cognitive deficits, visual spatial functions, or aphasia, and they may be amnestic, of course, but it's not the first symptoms in some of these cases. There are more focal local atrophy, like primary progressive aphasia or posterior cortical atrophy. And it has been shown that these patients with these focal syndromes have not they have not epsilon 4 ApoE alleles than those who are amnestic. And the second thing is that they are less agnostic. They do realize that something is wrong, and so because they are aware of their deficits, people don't think it can be a dementia. And finally, you know that the younger you are, the more genetic the the cause could be, and even if it's not the most frequent case, because it's only 10% of Alzheimer's disease who are hereditary, even in young age, but it's 5 more frequent than in older ages. Another characteristic is that these people have a lot of psychiatric symptoms, and especially delusion, hallucinations. They can be aggressive also, and they score higher on the behavioral rating scales. And of course, this is why these patients are considered as psychiatric patients for a long period, especially differential diagnosis with depression and psychosis. However, there is also some misleading symptoms in imaging, for example, because the hippocampal atrophy, which is considered as a good indicator of Alzheimer's disease, is not so important in young patients. They can have very global, severe atrophy, but some of them do not have a very severe hippocampal atrophy. However, the metabolism, the PET, the FDG PET, fluorodeoxyglucose PET, and the SPECT is not different from the oldest patients. So this can be a good examination to do in these young patients with difficult symptoms. And even if it's not available for care so far, the PET, the markers, the radiotracers of amyloid deposits, is completely the same. There is no difference in young patients and in old patients. So this can be also in the future something interesting in young patients. More easy to perform is the CSF, the lumbar puncture, which does not make difference in young and old people. So this is a very useful examination also to perform in young patients, because it may be even more discriminant, because the decrease of A beta and the increase of tau and the total tau and the phospho-tau is really present even in atypical clinical features. And we looked at 17 patients who came to autopsy or who had a mutation for Alzheimer's disease, and never the CSF was the CSF always helped us to make the diagnosis in life. There was only one case which was inconclusive, because it was not typical of Alzheimer's disease, and it was a Creutzfeldt-Jakob disease with a very unusual progression, very long progression of 5 years, which is very long for Creutzfeldt-Jakob disease. We looked also at the risk factors, because we thought that maybe the vascular risk factors that are very numerous and often seen in patients with Alzheimer's disease in old age. And we looked at these vascular risk factors in young patients, and we are surprised to see that a lot of them had hypertension and or hypercholesterolemia, and the diabetes was even a bit higher than in the general population of this age. We also looked at the lesions on the MRI, and we saw that vascular lesions were not rare, even if they were not as frequent as in old age. There was also this risk factor of depression, which was very frequent also in young patients. And of course, there is a family history of dementia in more cases than in young patients, than in old patients. Coming to the survival, all studies mentioned that young patients had a more rapid decrease and a lower survival, which is not exactly the case. The more recent studies show that there is a long survival, but a more rapid decline. So when the diagnosis is made, probably later, maybe because of cognitive reserve, for example, but after that, even the decline is very rapid, but the final stage remains for a long time because they do not die for another concomitant disease, probably. And I would like to say a word of the medical social characteristics also. There is a study in France called the Pixel study that looked at the caregiver or young patients and found that they were more exhausted, depressive, and they used more antidepressant and hypnotics than the caregivers of older patients. They have less respite places to resource them, and they express special needs like dedicated daycare because they are not happy with the daycare they have for older people. They need temporary respite care, and they need also financial support because, I said, it's not the same for old and young people in France. And they also noticed more behavioral changes than old people, with a lot of consequences: professional, financial, social difficulties. They mentioned also the dangerous driving, the violence against spouse or children. And they expressed also that they communicated very few about the disease in the family and even with medical doctors. They also didn't expect this diagnosis, of course, and even deny it. They also mentioned this anxiety of heredity of the disease, and they do not know how to face the end of life. And in addition, this is a sandwich generation because caregivers sometimes are responsible not only for their ill spouse, but also for their children and their parents or parents-in-law. For children, they face, it's difficult to face the decline of a parent, and some young children become the head of the family because the spouse is completely depressed, and this is a strange situation, and it's not well known. There are, of course, consequences on scholarship, friendship, and they may experience psychological problems. So we need studies in human and social science, and there is there is place for this family association, and the Alzheimer France Association is dealing with this problem more and more now. We looked in our active line of patients younger who started the disease before the age of 60, and we looked at the professional consequence. At the time of the first symptoms, 42% were at work, and some of them were already on sick leave, 12%. And more, which is concerning, is that 8% had disciplinary measures, with 20% were dismissed, including for incapacity, malpractice, or misconduct. And there are very few intervention of, I don't know, the occupational work doctors. There are some doctors in companies that didn't know well that this incapacity was related to a degenerative problem. And 82% lived with their spouse at home. That means that about 20 were not with a spouse, and 10% were completely alone, even if there was some relatives at proximity. The spouse was the caregivers in most time, but as I said, the child can be also a caregiver, even if they were young. And among these caregivers, 68% were still at work, which is a different situation than in older people. And 7 claimed to have professional problems due to the illness of their spouse or their parents. They also claim to have health problems due to the disease, and 40% changed their way of life, especially their leisure activities, and they also changed their relationship with friends and also neighborhood. And only 4%, I would say it's not too much, changed their family status, and it was related to the disease, mainly separation. We looked also at the medical pathway, because this is the big problem. At first symptoms, 80 consulted a general practitioner, which is quite logical. 28% have seen a neurologist, 6% a psychiatrist, and 8% an other specialist, and especially ophthalmologist because of the visual problems. And the first diagnosis was depression in 44%, or other pathology, completely unrelated, in 26%. And the Alzheimer's disease was the diagnosis that was made in only 22% at the beginning of the disease. And the psychiatric diseases other than depressions in a number of cases also. After we looked at the difference in patients with sporadic and with family cases, because we ran a cohort of family cases in Lille and Rouen, and 85% were sporadic cases, and 23 had a known mutation. The mean age at first symptoms was comparable. There was no difference between the MMS at inclusion at entry of this study. Of course, it was not the first MMSE they had when they first consulted a medical doctor. What we saw is that the sporadic cases had more seizures and they smoke less than the family cases. And the history was not different. The memory troubles were the first symptoms in most cases, but language or depression were also the first symptoms. The history of the first diagnosis was depression in the same proportion than in family and sporadic cases, but the consequences on the caregivers were different. The general impact of the disease were more serious, more severe in family cases, and the professional impact and the treatments were also more severe when the dementia was familial. Conversely, these family cases required and obtained more aids than those with sporadic cases. So this survey on family and sporadic cases didn't show any difference for age and severity of the disease, but more severe consequences on the caregivers, and the medical social aids were more important and more structured in family cases. If I have time, I will talk about the 2 measures that we had in the French plan. The first was setting a reference center for young onset dementia, and the second was to have indication about accommodations for young patients. So we answer we made an application. It was a grant for a multi-site reference. And there are 3 centers who participated with complementary competencies. In Rouen, this is the centers where all the family cases are referred for genetic testing. there is only one place for genetic testing for Alzheimer's disease in France, it's in Rouen, and for frontotemporal dementia, it's only one center, it's in Paris-Salpêtrière. So this is the way we know all the families that come to diagnosis in France. And Paris-Salpêtrière with Bruno Dubois were in charge of the assessment of imaging in these patients. And in Lille, we coordinated these centers, and we were more in charge of the management, and we ran this measure about the accommodations in young patients, and we also looked at biology, CSF, and plasma. And the first things we have done is to identify a referent in each regional memory centers. We organized in France each region, in each university hospital as a memory clinic, and in this memory clinic there is one medical social referent and a medical referent. So we can share all the experience together. The aim of this multi-site reference center is to improve diagnosis and genetic testing, and to improve training, to improve also the management and the research. And we have constituted a specific cohort using common specific diagnostic and follow-up procedures and collection of biological samples. And we encourage, and we have done, there are 6 studies of human science in these young patients going on, and we are also help as far as we can for public policies, health policies related to young patients, and we start to have some internal collaboration, including with NEED, the specific program in the Netherlands for young patients. And the accommodation for young patients, we didn't know where these patients were when they needed to enter a collective residency. And we evaluated the quantitative and the qualitative needs. We know that they're all in nursing home for old people, and this is our own problems, difficulties. But I think we are improving things thanks to this survey that we have done with the Médéric Foundation, which helped us to make this survey in all the settings that were able to welcome young people. I could come back to that later if you want. And finally, I would like to advocate for essentially in young patients, because usually these patients have no other disease, no comorbid disease, no other medications, and especially there are less vascular disorders or cerebrovascular lesions that are sometimes something which prevents them to participate in pharmaceutical research, for example. And these young patients are willing to participate in research programs, as well as their family, mainly their spouse, as we have seen, that are proactive and well organized to drive the patients to a specific center. And this young patient can be a lobby because they are still in active life, the patients and the spouse. They are not afraid of new examinations or technology. They are not reluctant to traveling. They are not resigned. They are not accepting the disease. They are less at risk of attrition. As in longitudinal studies, they die less, and they do not give up, never. And so far, they were excluded from clinical and pharmaceutical studies because of their young age, which is understandable because we wanted to have harmonization of a homogeneous group for research. But we also look at this wish they have to participate. It was our feeling, but we made a systematical survey, and we see that 58% of patients included in randomized clinical trials were younger than 65 years in our memory clinic. And the mean age for immunotherapy trials was 9 years in 2008. And when we asked systematically, we asked when we diagnose a patient, would you like to be informed if there was a study for you, clinical study, which doesn't mean especially pharmaceutical study. It can be to be involved in a cohort, or to give a blood sample, or to stay 5 minutes more in an MRI machine, for example. And most of the patients who agree were young. The mean age was 58 years, and the mean age of those who refused was 70 years, so much older, which is understandable again. Of course, the autosomal dominant form of Alzheimer's disease is a great model to develop disease-modifying drugs, and this is the international initiative, the DIAN, this study that started in the US, and which is prevention of Alzheimer's disease in relatives of people with a known mutation for Alzheimer's disease. However, we never know if the physiopathology is the same, whatever the mutations, and if it is quite similar to sporadic multifactorial cases. And there are also some ethical issues that are not very easy to solve. And the Mendelian cases account for 10% of the early onset Alzheimer's disease. So it's also important to understand why sporadic cases have a large range of onset, including at very young age. It would lead to strategies to delay the disease, I hope. So it's important also not to miss the atypical phenotypes with aphasia or or visual spatial disorders. And again, it's not such a difficult diagnosis as far as we are aware that the presentation can be quite different, because the biological and the imaging studies give confidence in the diagnosis of Alzheimer's disease, and this is probably the population in which this is the most useful, even when the clinical features and the age at onset are not typical. Young patients and families often in favor of autopsy, and I don't know if it's a current practice in Ireland, but in our memory centers, about 14% of patients who die give their brain for autopsy. And so this is helpful to validate these new biomarkers. Some young patients may be reluctant to participate in long-lasting studies with new drugs because they know that they are affected with the family cases, for example, and they want to enjoy their life and don't want to participate and to be stuck with very demanding studies. But they always agree to participate in proof of concept trials. They would accept repeating imaging and blood or CSF samples to show a signal in their biomarkers, even if it's not every month for 2 or 3 years. And I don't want to stigmatize on young patients. What I want to say is that these relatively rare young patients of today are representative of what will be the much more numerous old patients of tomorrow in terms of habits, likes and dislikes, abilities and skills, for example, transportations, information technology, communication, electronic devices. So in studying this population, we could anticipate the future needs the society will have to face. And this is why it's so important to have European and international collaboration. And with this, I will conclude that we have to keep in mind that in young patients, the features are atypical and there are numerous and difficult differential diagnoses. There is a long delay between the first symptoms and the diagnosis, 2 years more in our experience, and the diagnosis made at a more severe stage. There are a big social, professional, family and financial impact in these families. There are lack of specific facilities, there are genetic concerns, important research challenges, but the need of young patients of today are those of the older patients in the future. Thank you for your attention.